Hello everyone. My name is Mahmoud Salama, an assistant professor of OBGYN and the director of the Fertility Consortium at Michigan State University in the United States. Thanks a lot for joining our Fertility Consortium webinar today. The webinar will take about 1 hour in total, 45 minutes for the presentation, followed by 15 minutes questions and answers. Please keep your mic muted and your camera turned off throughout the webinar to avoid background noise and to ensure a smooth webinar broadcast. If you have a question, please post it in the chat. We will open the discussion at the end of the webinar with the ability to turn your mic and camera to ask questions. The webinar will be recorded and uploaded afterwards to our OncoForTit Consortium YouTube channel. For our webinar today, we warmly welcome our distinguished speaker, Dr. Hajra Khattak. She will give us a webinar on coordinating research in female fertility preservation, priorities, and core outcome sets. Dr. Hajra Khattak is a resident of OBGYN at NIH, University College London, and she is a clinical lecturer in reproductive health. She completed a PhD in reproductive medicine and surgery, focusing on evaluating the clinical effectiveness of ovarian tissue cryopreservation and transplantation as a method of female fertility preservation. She's also working on developing a core outcomes for female fertility preservation trials. She's also the founder of OvaREN, an international early career research group focused on driving innovation in ovarian research from basic science to clinical applications, as well as she chairs the UK Audit and Research Collaborative, a trainee-led organization to promote audit and research opportunities in clinical practice in OBGYN. So Hajra, we are warmly welcome you today. So please, stage is yours.
Thank you so much, Mahmoud Salam, for inviting me. It's an absolute pleasure, an honor, a privilege to be able to talk to you all about some of the research projects that I'm conducting at the moment, and hopefully you can all also get involved. So yes, I'm a resident in OBGYN. I'm based in London, University College London, but I'm a clinical academic. So I also am very fortunate to hold the NIHR lectureship, which gives me protected time to conduct research. So I primarily today wanted to talk about two things that I'm focusing on in my research. Before that, I wanted to, I have no conflicts of interest, but I do have fellowships and grants that have funded the projects that I'm talking about today. So to start off with, I suppose, what is the need for any of this? Why do we need to organize research? Well, firstly, there's lots of translation gaps. So female fertility preservation is gaining an incredible momentum. Although it's been there for over the last 2 decades, in the last few years alone, there's been so many advances and women have options that they didn't have before. There is still that lack of coordination. So there are different research groups sort of doing things, but some are collaborating, but there's a large gap in how the lab research, for example, is then translated into clinical practice. There's also scattered research efforts, as I briefly touched on, that people tend to be working in their own little pockets, and sometimes there are opportunities for collaboration. But some people may be working on the same question. There's lots of research waste, but it can also limit clinical impact. So if we perhaps had some sort of a database or some sort of one place where everything about FP is, collected, that actually we may be able to produce more impactful and tangible outcomes for patients, because that's the whole point in doing all of this from a clinician's perspective. So essentially, we need a unified agenda. We need questions that are of most relevance, not just for the researchers because they're curious, but also for funding. But importantly, above all, for the person sitting in front of us, so the patient that we see in our daily practice. So the whole of my talk will center around patients and public and people who have the lived experience of fertility preservation. And how we need to essentially prioritize these to meet the real world needs, because for those of you who do research is expensive. It's very difficult to be able to get funding to do something if it's not going to make an impact. So I have two objectives today, and this is to identify the questions that are a priority. So the research questions that are a priority in female fertility preservation, how I'm doing this and how you can help. And the second is how we can make sure that all the research that is conducted is giving you answers that you need and are of most relevance to patients, and those are the core outcome sets. So defining research priorities, it's a bit of a mouthful, and until I got to do it, I didn't know that it actually involves a lot of work. They need to be of clinical relevance, so they need to answer questions that are important in our day-to-day clinical practice. They need to be patient-focused, so they need to ensure that we're answering questions that patients want more answers to. We all know that medicine is not paternalistic anymore. What we think may be good for patients may not necessarily be something they want. They are the ones who've experienced it. They are the ones who should really be making all those decisions about what needs to be answered. But also, as clinician scientists, we need to, as academics, we need to promote the highest quality of evidence for anything that we offer patients. We need to make sure that it's based on good data, and it's relevant, but also of higher quality. So how do we do that? In the UK, we have the National Institute of Health and Clinical Research. And they sort of, I'm not sure if they're equivalent of NIH in the US, because NIH are very much sort of sets the ground rules for a lot of research related, whether it's projects, whether it's patient involvement, they kind of have a big say, and they fund. So I'm funded by them in my fellowship right now, but they also fund, clinical trials. And they devised this for something different. But if you look at the research cycle, it starts with identifying and prioritizing questions that are of most relevance. And most of us that are researchers are either designing or managing, undertaking or disseminating. So, for PhD students or clinician scientists, they're either doing an experiment or running a trial, or they're publishing. The implementation obviously comes under policy, and it's more guideline based. So some of us may also well be working in that area. But actually it all starts at the top. And if you don't get that right, the next thing is commissioning. You're not going to get funded. So an idea may be absolutely fantastic and it may be very well thought through, but actually it's not a priority for the government, or it's not a hot topic, or it's not something what patients want. And if I then talk about patients' involvement in research, so there's different checkpoints that they devised. And if you see, the research priority is absolutely the first thing. And then funding bodies strategically have these funds ring-fenced for questions that have arisen as a result of a particular method of research priority questions, as to how do we even come to a list of these questions, which I will explain in a second. But I guess the point I'm trying to make is that at the very beginning, your research question needs to be absolutely spot on, and it needs to involve the end user, which is the patient. And why does it matter, I suppose, in female fertility research? Latest advances, we've had incredible breakthroughs. There's more options for patients. I touched on this a little bit earlier, moving away from paternalistic medicine and actually making a decision with patients. How do we do this? Well, Or I suppose what is even the need of it is a lot of research areas in the UK, and a lot of, it's not just OBGYN, are involved, for instance, diabetes, and they are involving patients more and more in their research. And in big topics like that, there is a big, patient voices are quite big. Whereas fertility preservation, given it's been very much scientist / clinician led, actually we don't have much of a say from patients. And an example would be offering somebody ovarian tissue cryopreservation. As scientists and as clinicians, we know the pros and cons, but actually a patient might want it despite the cons being, a lot more, the cons being a lot more than the pros. And ultimately, I suppose it's better to be able to give patients both the options rather than assuming that this is what's proven and this is what they need. So we need to incorporate their voices a lot more in this area. Needless to say, we need to make sure that we start, because of how much fertility preservation is gaining momentum, we should really get it right from the offset, which is now, and that we avoid research waste, that all of us are working on questions, that we think will make an impact. So I wanted to talk about somebody called James Lind. He was a Scotsman and he actually cured scurvy. He was in the Navy, and I think he conducted the first, I think it was non-randomized controlled trial, but he gave some of the people on the ship orange juice or some form of citrus, and they were cured. And so this is in his memory. But this is an organization in the UK that gives you the means, expertise, and personnel to be able to come to a conclusive list of research priority questions. So they're a not-for-profit making organization. The aim is that they give you some form of templates and experts to form a steering group to be able to conduct. It's more of a Delphi process exercise to be able to come up with questions. And so these questions are then they will give you an information specialist. So, for example, I want to know what do patients think about the storage of ovarian tissue. I would like to know what patients' perspectives are in terms of follow-up. If we take that as an example question, the information specialist will go through that question in terms of a thorough literature search. So she'll search the literature for whether this question's been answered or not. If it hasn't been answered, it will make it to the list. That's the first round. The second round is the questions that we have selected based on the fact that they've not been answered will then be prioritized. So it will be sent once again to everybody, the group that's been formed as well as beyond. So it's a bit of a snowball effect. And then you will come up with a list of 10 questions. If there's any questions, I'll take them at the end, but I can explain this a little bit more. It always gets a little bit confusing. Those set of questions, those 10 questions. So for example, NIHR has a rolling funding call. So if you pick one of those questions and you apply for funding, you're more likely to get it because they're well thought through questions, including patient voices. So yeah, so I mean, they have a collaboration with the National Institute of Health and Care Research. An example is endometriosis. So you're welcome to go on their website and there'll be lots of other topics. I mean, no topic you think fit and it's there. The menopause PSP, the group that I'm working with at the moment have been instrumental in putting this together. And then miscarriage. So you can actually see for some of the older PSVs what's actually happened with the questions that have been funded, the impact that they've made, and then the guidelines that they have fed into. But it takes a long time to set this up. So we had to get funding to be able to afford the James Lind Alliance. We then have a steering group, which I think is the next slide. And we called it Preserve. So it's research priority questions in female fertility preservation. We're on their website. Our steering group is a really nice mix of clinicians, scientists, patients with lived experience, psychologists, oncologists. And we have disseminated the survey through all of our social media platforms as well as emails. We have a very strong collaboration in addition to steering group. So we are part of the ESHRE FP6, so that's the European Society of Human Reproduction and Embryology. The Oncofertility Consortium kindly is also a collaborator, and Mahmoud Salama, who kindly introduced me, is on our steering group. We also have the support of International Society of Fertility Preservation, as well as national groups such as UK Oncofertility Oncology Nurses, and UK STORE actually is a large database for tissue storage. But we of course need your help, because it's very important that we can spread this message far and wide, and it's very important that we have as many people as possible who can fill this survey out. So I would really strongly urge for you to either take a screenshot or get your phones out and see my cursor. So this is the QR code for the survey. It's currently live. It takes about 10 minutes, and it's going to ask you some demographic questions about what your role is. So are you a healthcare professional? Are you a patient who's considered fertility preservation? Or are you a patient who's undergone fertility preservation? And this could be any method of fertility preservation. And then a little bit about yourself, you know, where you're from, where you're based, and that kind of stuff. But then also there is they expect you to answer three give us 3 research project questions, but actually you can give more. And this could be anything. This could be, as I mentioned earlier, patient experience. It could be about what is the best method for a particular type of cancer, or how do we ensure that the success rates, you know, they are actually representative of the true success rates of oocyte cryopreservation, because most of it in the UK happens in the private sector. So no question is, you know, you can absolutely ask anything, whatever you're curious about. And if it's not been answered, then it may well actually feature on the top 10. I will have a slide on this at the end as well. So you're welcome to in the end also make sure that you've got it, and please, if you can also share it. We want it to be shared far and wide. If you're a clinician and if you've got patients in clinic, perhaps not when they're coming for their oncofertility checkup, especially if they're during cancer treatment, but if they're there for follow-up and you think that they're the sort of people who would be able to help us, I would really strongly urge if you can share it with them as well. So moving on to core outcome set. Core outcome set in a nutshell are all the outcomes that any particular trial in a particular topic should report when they are reporting a study. So if you have a randomized control trial, let's take the example of endometriosis. So all the outcomes that you want for endometriosis, so whether that's infertility or live birth or pregnancy or miscarriage or whatever you think, if somebody's publishing a research study, they should really report those outcomes. And so it's again sort of trying to homogenize and organize at the top. And how did this come about? Well, why don't we talk about how healthcare treatments are developed? So when doctors want to help patients. Excuse me. They make decisions about their treatments. And those decisions may be based on, personal experience or practice. But actually you need evidence, you need hard data. Treatments that are developed and tested by researchers to make sure that they work and that they are safe. What the researcher would then do is to look at the effects of those treatments on patients. So, what does aspirin do in a patient after heart attack, for example? And that is an outcome. So again, an example would be pregnancy rate after ovarian tissue transplantation. The problem comes when different studies report outcomes that they think are relevant or important. So one study may actually report on the AMH in a patient who's had ovarian tissue cryopreservation. So they might report the AMH before, after, and at certain time points, whereas for some, they may only do it before and not necessarily the same time points or at all after the ovarian tissue cryopreservation. Do they offer it before transplantation? So there's nuances in how people are conducting their studies, and that's when the problem arises. When those two studies are finished, the highest level of evidence is a systematic review. People who then want to put these studies together cannot put it together because they are not giving you the same answer. And that in some ways, again, is a research waste. It's based on perhaps one center's, if two studies are using the same question but answering different outcomes, then it's a bit of a waste, because had they joined forces or had they given you the same outcomes, you would be able to work from bigger data, bigger numbers, more evidence-based, more up-to-date data for that patient who's sitting in front of you. And so yes, if they all are reporting about the same health condition, then it would be so much easier if we could compare and combine that data. And that is the best use of research, essentially. As I think I've said a few times, avoiding research waste, and that's the bottom line. And so AMH or pregnancy rate or aspirin, that's one example, but there is a list of all the outcomes that we may want for a particular topic, and that set is called a core outcome set. And there is loads. If you Google core outcome sets for various conditions, we've just done one for male infertility trials. There's one for fertility in general, and they may or may not be. There may be different methodology to everybody kind of may have done slightly similar things, but it's a true Delphi process. You do a review, you come up with a list of outcomes from all the trials, and then you rank them. So you send a Delphi survey and you rank. So very different to the GLA PSP research priority questions, but also very, very important. So why do I think it's important, and why did I think of this? So during my PhD, I conducted a few systematic reviews, and it was really, really difficult for me to be able to answer certain questions, questions that were actually quite important to clinicians as well as researchers, and I just couldn't do it because there was not enough data. I could not give you evidence based on to patients. And that happened with whether I was doing a quantitative systematic review and individual patient data analysis, or a qualitative systematic review with thematic synthesis. So it was a very challenging task. And it was also not just the outcomes that were reported, but it was also uniformity. So for instance, labs have different assays for AMH, and sometimes estrogen and other bloods that we do for patients. and then me converting them to I mean, that's just a small example. So it was just very difficult to, and it wasted a lot of time. Had everybody done it in a similar way, I would have been able to provide more answers. And that's how the core outcome sets were developed, by providing a minimum number of outcomes that people can follow. You can actually make things a lot easier, but importantly, give patients the best evidence that there is. So this is our core outcome set protocol. Is currently on the COMET website. So the COMET website is it's where you register your core outcome set. It's currently ongoing, so we've finished the review, and we will launch the survey at some point this year. And I will circulate it to all the OncoFertility Consortium members. And this survey is a little bit longer because the number of outcomes are quite a lot. But ultimately, there's 2 or 3 rounds of a Delphi survey, and you produce. There is no minimum for the JLA PSP. The minimum is 10, but in this, it's the most important outcomes that there are. You also need patient and public involvement in this, so it cannot solely be just the clinicians. It needs to include patients as much as healthcare providers. So quite a lot to think about, but what's the future? And I feel we need a future where we can connect discovery scientists and clinicians to be able to improve translation of research in this area. There are fantastic groups. People are doing brilliant research. And there are lots of great organizations like the OncoFertility Consortium, and we need to keep the momentum going. We need to make sure that we are doing things that are in the best interest of women that is sat in front of us in the clinic, or somebody who, was born female at birth. And there's various layers and parameters to how FP can fit into a woman's life. In Europe, we don't necessarily have like a pan-European network of patient and public representatives. This may be ambitious, but I think that's what we also need, a group of motivated individuals for whom it may actually be really hard to talk about because it's an emotive topic. But we cannot move forward without their experiences because it would not be fair to them. And so I founded OvaREN, which was the ovarian research network for early career researchers. And it is a way of starting the conversation early. We are working on the patient and public side of things, but at present, there is 6 of us. We're all from diverse backgrounds. We have embryologists, we have laboratory scientists, there are clinicians on this, and we are trying to involve as many people as possible. We are very loose on the sort of criteria for early career researchers. So you could either be doing a master's or a PhD or be a few years into your PhD. I guess what we're saying is as long as you're not a professor with your own group and you're not a PI, then you can essentially join us. And the structure of this network is essentially having an executive committee, have this membership, and we hosted the first ovary workshop. So it's the European ovary workshop that took place in February this year. And the idea is that we continue to be a part of that. This OvaREN was part of that, but also have particular like pre-Congress workshops. But we want to be slightly different in that we want to start all the communication early and not when we are at the EI stage. We are in the process of launching multi-center research projects We are also going to do some webinars, and hopefully Mahmoud can help me share them. We're always open to collaboration as well. At the European OvaREN workshop, we also had a mentorship program, and we hope to secure future grants to help the movement of early career researchers within different organizations. So join us. Again, please take a screenshot, and it will be on the recording. So yeah, it would be lovely to have you all on board. We are not Europe. I mean, most of us are European, Europe-based, but we're open to international audience. And I'd just like to take this opportunity to thank everybody that has helped with all the projects that I talked about today. But importantly, the patients that have helped me come this far. We truly cannot do this without them. And I just want to leave you with this. On the left is the QR code for the Preserve the JLA PSP Research Priority Project, and on the right is the joining list for OvaREN. We are fairly new, so we're fresh, and if you have any ideas, we'll be very keen to join. The JLA PSP is going to be open, the survey, until around mid-July this year. But if you have an interest in joining the steering group or being involved, then please feel free to email me. I've put my email address on there. So that's it for me. I'm very happy to answer questions.
Thanks a lot, Hajra, for this amazing talk and initiatives, really very exciting. So we have now time for questions. I have some questions I can start with now. So, regarding the initiative OvaREN, your amazing new organization. So, what is the next event for OvaREN that we can promote for? So, you already had this workshop, right, in Portugal early this year. So, what is your next event?
Yeah. So the next event is another workshop that is going to take place in 2027, and we're thinking of Spain. So the Spanish team are working on it. We want to continue the legacy from the workshop because it was one of a kind workshop. And so we will have around 6 webinars based on the life course. So all the way from within the, fetus to adolescent, pediatric and adolescence age, all the way into the reproductive years and menopause. So we are doing the webinar series, and I would really hope if Oncofertility Consortium can get involved, hoping to launch around this summer. We will also be having some sort of exchange programs. So we are thinking how there could be a movement across labs. So if Oncofertility Consortium, if you have a group of early career researchers, I think it'd be really helpful to have their input as well. So those are for the next sort of 2025, going into 2026. And then obviously we'll start preparing for the OvaREN workshop. So it would be so lovely for all of you to come and make it an international rather than a European event.
Yeah, sure. This will be very exciting for us to join and promote for. So the last workshop, actually, there were hands-on workshops, right? The parts for ovarian tissue freezing.
Yeah. So because it was in Portugal, it was very difficult to take the equipment there.
Mhm.
But the isolated workshops is something that we could offer to the exchangees. So, for example, Copenhagen does a hands-on workshop. So we're trying to get some funding to see if we can send some of the early career researchers, especially clinicians, because they don't do lab work unless they have an interest. But for the next workshop, things might be different. Let's see.
Mhm. Okay, very good. Another question on the ovarian tissue cryopreservation practice in the UK. So, is OTC still considered experimental in the UK, and how this affects the practice, for example.
Yes, so the British Fertility Society have a practice guideline on female fertility preservation, and it's not considered experimental anymore. Actually, it's not been for a long time now, years, I would say. It's just because it is offered on through national funding, there is issues with who gets it, and there is a handful of centres in the country that will offer the freezing procedure. So the retrieval, any laparoscopic surgeon can do. But to be able to freeze it, you obviously, as I'm sure you know, you require a lab. So there is not that many labs. There's a handful of labs in the UK. And patients can't fund it privately. So I think that's one of the issues, but it's not experimental anymore.
So NHS funds the OTC procedures for patients, or patients should have private
Yes.
source of funding to do that.
Yes. Yes. So for the centers that offer it and they
Mm-hmm.
have a bank on site, they will offer it under NHS funding, as far as I'm aware.
Mm-hmm. Okay, very good.
Or they have a charity. So Oxford, for example, had the Future Fertility Trust. I don't know the nitty-gritty, obviously, because I don't work there, but it's the patients don't pay for it, is the bottom line.
Mm-hmm.
They may
Okay.
pay for storage, sorry, they may pay for storage per year, but they don't pay for the procedure. So the retrieval, they don't pay for the surgeon, they don't pay for any of that.
Yeah, very good. So at the end of this really amazing talk, yeah, we can feel that really you and your colleagues really did a lot as a young researcher. So, what's your message to the young researchers in the field of female fertility preservation?
That if you're in love with this topic, then just follow your heart, I guess. I think there's still lots that needs to be done, and sometimes it feels like you're fighting an uphill battle because there's no funding in this area. Even within women's health research, it is incredibly niche and it cross covers with cancer and some pediatrics. So there's lots to do, but if you're really in love with it and if you really see the benefit in doing this, then you should stick to it and keep fighting.
I have a question, if that's okay.
Of course.
Sure.
Um, I think that you talked a lot about the patient experience and lived experience, which is integral, of course, to any intervention or any research. And yet, when you mention about the lack of funding available, right, it's challenging to engage patient partners in a very meaningful way, because oftentimes, unfortunately, they're not able to be compensated. Like if they're, we haven't found a way to do that. So just wonder about your thoughts in terms of incorporating that patient and family voice without a lot of funding available.
So this is a really good question, actually. So in the beginning, I talked about some of the grants. So I actually got funding from it's called a PPI fund, so patient and public involvement. And it's not very much, but it's to compensate them for their time. So every time I am applying for a grant, or I'm not sure what happens in the US, but now you have to incorporate some pot of money for patient and public because they can't do it for free. The NIHR actually has a really nice guide of how much they think we should compensate patients for their time. So if we give them something to look at in terms of a paper or a policy. And if that takes, say, 3 hours, then we should compensate them for that. If we are asking them to come and be part of a steering group, then we pay them for their time. So I don't know if this answers your question, but essentially I make sure that every time I ask for funding, I absolutely have funding for patients and public, because it's unfair to ask them. That is true.
Yeah, thank you for that. So the guideline would be available on the NIHR website then?
Yeah, so I think if you do NIHR
Yeah.
patient and public, so if you do NIHR PPI, the internet's
Okay.
not best here, but actually it will give you a really nice guide. If not, write to
Okay.
me and I will find it for you.
Okay, great. I appreciate it. Thank you so much.
And if you want to collaborate on anything, very open to collaboration. So
I'll definitely, I took lots of screenshots and we'll share definitely with the team. I think that, there's always opportunity. So yeah, thank you so much.
thank you very much.
It's a good chance, Julie, to introduce yourself as well. So people may collaborate with you. So
Oh, you know what? I am a project manager for fertility preservation at the Hospital for Sick Children in Toronto. And so it's for pediatrics. Again, I could relate to so much what you were saying in terms of, putting best practice into action. And so my role is really taking the evidence base and integrating into pathways, not only for oncofertility, but also across for children with other congenital, conditions or medical conditions that would impact their fertility. And so we're approaching it from a very multi-pronged kind of way. And research is definitely one of the ways of, you know, trying to get people on board. So, because I think that while people wholeheartedly believe in it philosophically, I think in practicality, there are challenges in implementing because of different priorities, I think. Right. So if someone is medically fragile and, perhaps the physician does not feel that, fertility preservation is, at the top of the list, and it certainly isn't.
yeah,
But I think just the importance of those conversations, right? And it's, we're trying to make it as um, easy as possible to have the conversations, document them, make the referrals, to the endocrinology team, gynecology, endocrinology, to have the conversation. So, we're up and running, but I do think that, of course, research opportunities, um, always augment the work at hand, um, but it's challenging given time and funding. So, you know, the collaboration opportunity is always wonderful to consider. So,
you got already a very good collaborator. So collaborator Hajra, I think.
And
So
honestly, I'd love to talk. Please
yeah.
do write to me, Julie. I
okay.
have a question. So how is the fertility preservation funded in your unit then?
Yeah. So right now, the so are you talking about the actual procedure, like the OTC?
Yeah, or even egg freezing if they are,
Yeah.
you said children, but if
Yes.
they're teenage girls.
Yeah. So currently, it is we have collaborators. We have Mount Sinai Fertility, which is another very large and wonderful collaborator that is actually doing the preservation piece and the storage piece pro bono. Like they're actually doing it, for free at the moment. However, there are grants and proposals that have been submitted to our ministry to look at, ongoing funding for this important initiative, right? Because it's not sustainable, clearly. So right now, what we're trying to do is actually gather as many metrics and data as possible in terms of, numbers that, for example, would be referred for a consultation, and then the actual numbers of people that, either go for oocyte retrieval or OTC, and then really lobbying the government to pay for it in a way that we can sustain this work. So the storage fees, of course, can be very prohibitive to families. Um, yeah, so I mean, we're looking right now at sort of like a hub and spoke model, so that Toronto is kind of the base where the storage is and the expertise involved in preserving the tissue. But then, of course, there's, Canada's or Ontario, our province is huge. And so looking at ways of also incorporating the cost of transportation, right, of tissue.
Yeah.
So there's lots of pieces that we're currently working on.
Fair enough. Sounds about the same here.
Does it? Yeah.
Yeah. I mean, I'm quite junior, so like I don't necessarily get involved in the policy side of things, but obviously you hear it and you're part of the team. So I think it's the same issue, and
Yeah.
the National Health Service obviously can do only so much, but there are certain centres, especially like where I am now, we're very lucky. But not everywhere is like this. So yeah, we must keep up the momentum and keep going.
Yeah, for sure. For sure. Absolutely. And are you planning to come to the Go Fertility Consortium?
Yeah, I make plans every year. Maybe we'll
Okay.
see. It normally coincides with other conferences, so then that means too much traveling and very little clinical work. But I would love to. Are you going?
I'm trying to convince my manager that I should go. So
Of
um
course, yeah, all of you are welcome really to attend the annual meeting this
yeah,
year of the OncoFree Consortium. So the meeting will be on October 13th to
yeah.
15th in Detroit, Michigan, and we'll be very happy to see all of you.
Yes.
And yeah, if not, I'm going to connect you as well with my amazing team. Dr. Jenya McKaylee is such a strong proponent, and I know she's going in October. So I'll make sure that you have a conversation or connected with her as well. So I think there's lots of opportunity.
So, Hajra, thanks a lot again
No,
for this amazing webinar. We will keep in touch, of course, for continuing your initiatives and promoting for them. And yeah, the last word for you before we end the webinar.
Um, we really need your help. That's all I wanted to say. And if you're watching this and if you're a healthcare provider who provides fertility preservation services, and if your patients are, of course, not in their cancer journey, and they're there for follow-up, if you deem it feasible, I think it's very important for us to do this for the patients that we see in our clinic. If all of you who's watching can fill this survey, it's really not that long. And if you want to get involved, please write to me, always looking to collaborate. And thank you so much for the opportunity.
Thank you so much. Thank you. Bye bye.
Thank you. Bye.